here and everyone who's online. So today I'm going to talk about common skin diseases. So these are the topics I'm going to cover. So atopic eczema, the commonest disease that I see and also seen in general practice. Irritant contact dermatitis, allergic contact dermatitis, infections, psoriasis, some connective tissue, blistering, drug-related, and a few miscellaneous conditions. So atopic dermatitis is so common. I think we see it like every day. So basically when the patient comes, they always come with this kind of patches, usually at the flexural areas. And typically in atopic dermatitis, the borders are not well defined, meaning you cannot actually draw a nice round circle around the borders. If you can draw a nice round circle, oh, okay, more louder, okay. So if you can, if you can draw a circle around your lesion, it's actually not atopic dermatitis. It's most probably fungal or something else. However, if the lesions are very thickened and lichenified, like the second picture over here, you can see that it looks like a plaque actually. So it becomes thick, and these ones are well defined. It just shows that the lesions are very chronic. Okay, so this is second picture is a lichenified plaque. So overall, in patients with atopic dermatitis, the skin will generally be dry. It's impossible. They have moist skin and atopic dermatitis. And also, they are very prone to infections because of their impaired skin barrier. So they will have infections with molluscum contagiosum, herpes infections, fungal, impetigo, and many types of infections. And they will have atopic history, rhinitis, allergic conjunctivitis, and asthma. So it is actually a clinical diagnosis, okay? So there is no testing that is needed. There is actually some criteria that it can be used, but mostly done in research only lah. So clinical setting, just clinical diagnosis. A lot of parents will ask for blood tests, okay? So they will ask to do IgE allergy blood testing. Generally, in adults, I never do that, okay, because it will lead to, false positives, and then the patient, if you're an adult and you avoid foods, it's okay lah. But in children, when they have a lot of false positive and they start to avoid many foods, and then they can have malnutrition. So generally, even with kids with eczema, I'd say no need to do allergy test unless it's a very severe eczema involving the whole body, then you might want to consider. Patch testing, on the other hand, may be helpful if you find that after, you are giving all the moisturizers, the steroid creams, and you find the eczema is getting worse and worse and worse, then you can consider is the patient allergic to the creams or not. So that case, you can do patch tests. So this one is to rule out allergic contact dermatitis. Okay. So atopic dermatitis is the most common skin disease in children. So in 10 to 30% of cases persist to adults. In our Malaysian population, is around 10% goes to adulthood. And then some are affected during young adulthood only. During children, they're okay, and then they get affected during young adulthood. So it's more prevalent in more industrialized countries. So the factors that contribute is multifactorial. Genetics is a strong component. The immunology of the blood of the patient, epidermal barrier dysfunction, and environmental factors. Okay, so this is the atopic triad: asthma, allergic rhinitis, and atopic dermatitis. Okay, this diagram here is called an allergic march. So it indicates that in the beginning, when the child is very young, what they have is actually eczema. Okay. So when the child is very young, meaning like 1 year old, 2 years old, what they can have is is eczema and food allergy. As the child is growing up, the eczema will be tapered down. You see the food allergy also tapers down, and then they may start to get asthma and rhinitis. So this thing is called an allergic march. Okay. So it is autosomal dominant. So if one parent have it, it's around 60% chance of the child to have atopic, all the types of atopy. If both parents are atopic, 80% of the time the kid will have a atopic disease. And this is important because now the mental health is a pretty big topic. And then a lot of studies are showing in kids with atopic dermatitis, they may exhibit some autism spectrum symptoms. Okay. And then in adults, hypertension, obesity, infections. And yes, the comorbidities depends how severe the eczema is. If the patient has severe atopic dermatitis, they will have more depressive symptoms or anxiety. And then sleep disturbances is also in more severe cases. Okay, so the management of atopic dermatitis is always to moisturize. Is the main thing. A lot of times when the patient have seen GPs, they are always put on steroids as the first line. Okay, but actually the moisturizer is the main treatment because the root cause is to restore the epidermal barrier. And then for patients with atopic dermatitis, we prefer cream or ointment-based moisturizers, not lotion-based. Okay, so we have lotion, creams, and then ointment. Lotion is very light. And most of the time, atopic dermatitis with lotions, they don't get moist enough and they might also have some stinging feeling. How often must you moisturize? In the acute phase, you should be moisturizing every 2 hours. When the patient is better, 4 to 5 times a day. And as the patient gets better, maybe just two or 3 times. So usually it's after showers, you tell them to moisturize. And they must shower once or twice per day only, or in short showers, which is around 15 minutes. So some patients tend to shower many times, 4 to 5 times a day is to relieve the itch. So this one, we need to advise them not to do that. Okay, we do use a wide range of topical steroids, depending the age of the patient, the location that you want to apply, and how fast you want to see the effect. So hydrocortisone and clobetasol butyrate and Foban Hydro, generally I use for small children. When they come to teenagers, then we go to Fusicord, Mometasone or Elomet. And Elidel and Protopic are the two, these the only two available in Malaysia that is non-steroidal. Okay, so Elidel is made from pimicrolimus, Protopic is tacrolimus. So these are non-steroidal, can use on the eyelid as well. Because we don't use steroid on the eyelid, which can cause cataract and glaucoma. So only these two can use on eyelid, on genitals, and also can be used long-term. Antihistamines, generally we just stick with sedative antihistamines at night. During the day, you might give some non-sedative antihistamines. Okay, antibiotics and oral acyclovir, this is in individual cases. If you think there's an infection, better treat. And antifungal, okay? A lot of the times when the patient have applied so much of steroid creams, they may get a secondary fungal infection. So what we do, actually, we scrape the skin and then send for culture or microscopy. Then we start some oral antifungal. Hi. Okay, the second commonest thing and sometimes not so well diagnosed is contact dermatitis. So you have two types, irritant and allergic. So the easiest way to remember this, irritant means everybody is actually, all of us will react to it. However, allergic is only certain people will react. For example, if all of us put our hands in Clorox, we will get a contact dermatitis. So that is irritant contact dermatitis. Okay. If certain people like us, like me, allergic to nickel, so there's some earrings or watches that we cannot wear, then that's when we get allergic contact dermatitis. So this depends on the individual. Even using detergent, if all of us touch Dynamo or what on our hands, we will find that we'll have contact dermatitis. Frequent hand washing, frequent hand sanitizing can also cause irritant contact dermatitis. So when you talk about allergic contact dermatitis, irritant happens at that time itself. Allergic is a delayed response. So our skin needs to be exposed many times to the same allergen, then the symptom will appear. So common ones is nickel. okay, in earrings. Perfume is a common one. Adhesive is a common one, especially in like Handy Plus or the plaster, micropore plaster. So this one is allergic contact dermatitis. So this picture here was for, I think, cement allergy, the first one, and then this is nickel allergy. So the management is basically, you need to find out, oops, table is very small. You need to find out what is the cause of, what is the allergen, basically, what is the allergen, and then see whether that allergen actually correspond to the right location in the patient. For example, if you think the patient is allergic to lipstick, of course, you would more see on the lips, around the face. If you think the patient is allergic to hair dye, also you should see around the scalp and then on the back. So you have to see if that allergen responds to the symptom or not. So allergic to hair dye wouldn't really have a hand dermatitis unless the patient did their own self the hair dye. Okay. And then, so allergic contact dermatitis, you can also diagnose with patch testing. Irritant contact dermatitis, generally we don't do patch testing because the effects will be very, it will have a lot of irritation. Okay, and also another form of treatment, you must tell them if you must continue to use the whatever allergen, you have to protect your hands and protect yourself. Okay. So the next commonest thing that we all see is actually fungal infections. Okay, this one is so common. So generally they are circular or annular lesion. The center is clear and the periphery, it can be, generally it's not smooth. It's like papules like that. It's reddish papules. And then you find that the lesion will expand without treatment or with the wrong treatment. Okay, you can have one or you can have multiple. And they are never symmetrical, so they'll be distributed anywhere. They have fine scales, and sometimes they may be immunosuppressed, and they can have nail changes. Okay, so these nail changes you might be confused with psoriasis of the nails, but if you culture it, you can easily diagnose. Okay, so the management of tinea infections, which is tinea corporisca, tinea crurisca, anything of those, you scrape it for fungal culture, and also then you start topicals. So generally, if it's very severe, I start topicals plus oral straight away. So topicals, we use terbinafine gel, miconazole cream, clotrimazole cream. Most of the time, actually, these antifungals are mixed with topical steroids because tinea is very itchy, so you need some steroids to reduce the itch. Okay, and then oral antifungal, we use itraconazole or Sporanox, and then fluconazole. Itraconazole, we will give a dose of 200 mg daily for 2 weeks. Fluconazole, we will give 1 tablet weekly for 3 weeks. Okay. Sometimes you may need more longer treatment depending on how extensive the skin lesion is. And then you can monitor the LFT. If the patient has comorbidities or have fatty liver, better you monitor the LFT. And then I use these antifungal shampoos. I use it, ask them the patient use as a body wash. So this is additional. And then generally when I tell them after the skin lesions resolve, you just use the antifungal shampoo as maintenance 2 or 3 times a week. Okay. Anything else about fungus? Okay, that's all. All right. Infections, bacterial infections. Okay, cellulitis of the legs usually. And impetigo. So in this picture, the golden honey crust appearance is the typical one. Sometimes you get this on the face, and then on the body you get these things. Okay, so which are actually bullous impetigo. All the bullous pecah, so it looks like this. Right, and then it's always mistaken as chicken pox somehow. This lesion, when it's small especially, they get wrongly diagnosed as chicken pox. Okay, so generally it's caused by gram-positive bacteria. Okay, so this part I think we can skip. So the commonest one is staph and strep or skin bacterial infection. So staph looks like this, the bunch of grapes, and then strep is in a chain. So generally it's a group A strep, okay, that causes impetigo. So bacterial infections can cause a range of skin lesions. Carbuncle is one. Ecthyma basically looks like a small black eschar like that. Okay, erythema, it's a fungal, it's a bacterial infection generally involving the axilla and the feet. Okay, always will be misdiagnosed with fungal folliculitis, inflammation of hair follicles. When there are many folliculitis, they come together, they can form furuncles. So furuncles is like boils or bisol. Then impetigo is more superficial, lymphadenitis, and then you can get abscess. Okay, more serious is cellulitis. Erysipelas is a form of cellulitis. It's a localized form of cellulitis, and it has lymphatic, it follows the lymphatic drainage. Okay, so it most of the time can happen on the face or on the legs. And then can get necrotizing skin infections, SSS, Staphylococcus scalded skin syndrome in children, and can have wound infections. Okay. So impetigo, very important and then very easy to treat actually. So it's caused by the strap of staph, and it leads to lifting of the stratum corneum. So that's why they got the bullous lesion. So lifting, and then it forms crust. Okay, so it commonly affects children, spreads easily, especially from the nose. The patient touch the nose and touch the surfaces. And then it can go on damaged skin or actually normal skin. So, and it's itchy and slightly painful. Usually it's around the mouth and the body. Okay, this is ecthyma, so it looks like an eschar. So it's more deeper form of impetigo. So it happens in children, in adults. I'm sure I've seen this in diabetic people, diabetic patients on the legs especially. They get this blackish, looks like ulcers with something black. These are actually bacterial ecthyma. So when they get larger, they can have pus inside. And they are very, very slow to heal and quite painful also. Okay, cellulitis, commonly we see this. So it is infection of the dermis and it can go up to subcutaneous. And it has poorly demarcated borders and it's caused by strep or staph. Actually can be caused by anything like Pseudomonas or any type of bacteria. Commonly affects the legs, but can also happen in the hands and the face. So you have pain, swelling, tenderness, redness, and warmth. So all the forms of, all the signs of inflammation. Okay, this is what I mentioned to you, erysipelas. So it is a form of cellulitis. The difference is the borders will be very sharply demarcated. Okay, and then it's most probably caused by strep. The difference is, what's the difference you want to diagnose erysipelas or cellulitis is erysipelas actually takes longer to get better, and they may need IV antibiotics. Compared to some mild cellulitis, we can just treat with oral antibiotics. Because erysipelas goes into the lymphatics and that can be quite slow to heal. Okay, folliculitis, we see this a lot. It happens on the back, sometimes on the abdomen, scalp. So it's most probably caused by staph, and also there's something called a bathtub folliculitis. This one is caused by Pseudomonas. So it is after the patient sat in a bathtub, come out, the bag is full of like acne-like things. That is bathtub folliculitis. Okay, this is furuncles. So furuncle, another name is boil. So it is basically infection of the hair follicle. A few hair follicles that comes together and then they form furuncle. Okay, and it can happen basically anywhere, especially at the waist, the groin, the buttocks, and the armpits. Carbuncle is even larger form of boil. So it is a lot of hair follicles that's involved with pus, and then it's very deep, and then usually on the nape of the neck or at the buttock. And then most of the time, the patient has diabetes. So this one definitely needs a surgical wound debridement or saucerization. Okay, so bacterial infections, if it's bullous cellulitis of the legs, such as this picture here, generally what I do is potassium permanganate soaking or wash. So potassium permanganate's property is antiseptic, reduces swelling and inflammation. Oral antibiotics, or if not improving, IV antibiotics, 7 to 10 days of it. Okay, and then the process is the bullous will rupture, then it will dry up, and then the crust will take quite long to get better. Okay, that's cellulitis. Scabies, common infection, and sometimes also misdiagnosed. Okay, so scabies generally it forms, what we know is that it goes in between our finger web space, toe web space. But in adults, it can be more generalized like this. So just full of papules all over the body. These borrowed tracks, we can't really see with the naked eye. You need to use magnification. Then you may see, especially in between the fingers. So this is the mite Sarcoptes scabii. So for adults, you see on the body and the skin folds, okay, armpits around the waist. So there's another form of scabies called Norwegian scabies. So this kind of Norwegian scabies, I think this picture is Norwegian scabies actually. It looks like crusty lesions in between the fingers and toes. It is very, very contagious because they contain like, I think it was 1,000 times more of scabies mites compared to a normal non-Norwegian scabies. So it is highly infectious and is usually found in immunosuppressed people or patients in nursing homes or those homeless people. They will usually have Norwegian scabies. So it's much more, can be much more contagious, so must use gloves when you touch the patient. Okay, so differential diagnosis for scabies, then we might think that it is like the dust mite allergy or insect bites. You might misdiagnose as fungal or dermatitis pompholyx. Pompholyx means the BGIA in the fingers, or urticaria or bullous pemphigoid. So all these can form blisters and can be misdiagnosed as scabies. So the contacts must be identified and treated. All the things that are fabric, like linen, the bed sheet, towels, clothing must be washed with hot water. Things that you cannot wash, if you can, you need to seal them and don't use for a week, because these Sarcoptes scabii, they eat the skin, dead skin cells. So if they got no skin cells to eat, they will die. And then the room needs to be cleaned. Fumigation is not necessary. Floors and furniture all needs to be vacuumed. So generally, this is, I always use SCAPs, or which is permethrin 5%. For more than 2 months old already, I use this. Okay. EBB, I see a lot of GPs are still using EBB, and I find it's not so effective because after a while, the patient still gets the, like after a few months or so, the lesion still there. So Malaysia actually have a CPG for scabies. It's 2015. So permethrin, benzoyl benzoate or EBB on sulfur. Generally, we use just permethrin. Okay, and sulfur, I guess this one is like, I don't know whether it works or not, but it's for, say, for infant and pregnant ladies. Okay, others that can be used is scrotameton. Also, it's not really it doesn't really kill the mite lah. So basically, it just causes like, it form a layer and then it reduces the itchiness. Lindane, generally not used so much because it is neurotoxic, so it can cause seizures if used on the whole body. But you can find lindane for the hair lice treatment. That one is easily available, but that one is just we put on the scalp, not the whole body. Ivermectin, yeah, we can give ivermectin for more very severe Norwegian scabies, but generally it's not needed. Okay, this is the how it presents and how to treat. This one you can read from the CPG lah. Okay, another, what to say, common, it's common for me. It's quite common for me. It's actually psoriasis. Okay, in GPs, I think it's not so common lah. So the patient will generally come with this kind of plaques on the elbows, knees. This is the general one, and the scalp. but they may also have plaques at the flexural areas as well. Sorry, at the extensor area, flexural area, yeah. So folded areas, they may also have this kind of plaques. So they can have it on the cubital fossa. This picture is inframammary, buttocks, in the perianal area as well. Because you always will think psoriasis is on the external part. But if it happens on the internal part, it's a possibility. It's called flexural psoriasis. Quite common, this one. And then it is usually symmetrical. Okay, you can see these ones are symmetrical. The inframammary also symmetrical. And they will always have a family history. Most of the time they do. Sometimes it's a bit a distant relative, but they do have it. And they may have recent infections like URTI generally that precipitates it. Okay, it's sometimes itchy, sometimes not so itchy. Then you look at the nails. If you suspect that is psoriasis, like the one under the breast is commonly misdiagnosed as fungal. It's always misdiagnosed as fungal, but if you're not sure, just have a look at the nails. So in the nails, if you see the classical changes of psoriasis, like you see the nail is lifted, and then it's not smooth, and then it's a bit yellowish, so these are psoriatic nails. And generally, it will involve a few nails. It won't be just like 1 or 2 nails. Okay. What can look like psoriasis, but it's not psoriasis. So a form of eczema called discoid eczema. So they form a small disc, okay, or like coin-shaped lesion on the legs. And these ones are sometimes is misdiagnosed as psoriasis. And they're usually quite wet. So this discoid eczema actually is, most of the time is wet and forms crust. Okay, psoriasis is never wet. Psoriasis is always dry. And then discoid eczema is always on the legs, and the patient will have history of atopy, and these are non-symmetrical, non-scaly. So it's more of papules and vesicles. Another thing that can mimic and psoriasis is lupus, okay? Cutaneous lupus. So cutaneous lupus, like in this cutaneous lupus, there's acute, subacute, and chronic, all right? So in acute is malar rash, subacute looks like this picture in the top here, which looks maybe can look like fungus a bit, psoriasis a bit, all right? So it's like patches and plaque, where it look like central clearing actually. And most of the time is female. If you know, lupus has a 10:1 ratio male to female. Chest and face is a common area because of the sun exposure. And then the hair may have hair loss. So acute lupus is malar rash. Subacute lupus looks like this fungal kind of infection. Chronic lupus is like discoid LE on the scalp. So all the forms of lupus looks different. And then it's not itchy. Most of the time we need to biopsy this lesion just to confirm the diagnosis. All right. So psoriasis patients will always have comorbidities. I think I've never seen a psoriasis patient without. So either they are very obese, and then they may have high blood pressure, diabetes, high cholesterol, fatty liver. Then they may have cardiac problems as well. So this is the screening that we will do for the psoriasis patient. And then besides screening for comorbidities, you screen for the joint. So this questionnaire is the most famous one for screening for joint involvement. It's called PEST, Psoriasis Epidemiology Screening Tool. So you have to answer the 5 questions. Do you have swollen joints? Has a doctor told you you have arthritis? Is your fingernails does your fingernails or toenails have holes or pits? Do you have pain in your heels? Do you have any finger or toe that become completely swollen? So if they answer 3 or more, actually it's indicated that you need to refer. And then you just tick which joint is the problem joint in this picture. So psoriasis, most of the time, is asymmetrical. Okay, grading of psoriasis. You can use this physician global assessment, very general. So clear, mild, moderate, severe. Or you want to count by percent, you use body surface area. You use the patient's palm, is indicate to 1%. And then you see how many percent involvement of their body, also can. For clinical trials, we use scoring systems, which is called PASI, right? And then also for quality of life, we use this DLQI, Dermatology Life Quality Index. This DLQI also used for other dermatology diseases, not only psoriasis. So it goes through like everything they ask until sexual, social, and everything. Okay. Treatment of psoriasis, a moisturizer, tar-based preparation. So tar-based looks like this, looks a bit dark. And then steroids, and corticotriol is vitamin D analogs. Second line, if you fail topicals, your second line is to use systemic. So use methotrexate plus folic acid and acitretin. So both of these are teratogenic. Acitretin, once the female patients consume, they cannot have any pregnancy for 3 years. So we don't usually use it in the female childbearing age. Methotrexate you can actually use for female in the childbearing age, but they need to be on contraception. Okay, so methotrexate, there's an oral form and a subcutaneous form. Because the side effect of methotrexate is they may have a lot of GI, nausea, vomiting. So if they cannot tolerate it, then you can give subcutaneous. But it's a very highly effective medicine. So this is a blood test that you do, FBC, lipid, pregnancy test, and ask about the LMP, last menstrual period. So when to refer, when you try topical and not improving, this is one patient of mine. So it's like almost the full body is covered. So a patient like this will need systemic treatment, cannot use topical already. And then this is a guidelines to see like in diabetes, you know, there's HbA1c. So in psoriasis, they also have guidelines. So if you must bring down the body surface area by a certain number and the PASI by a certain number, then you know that it's working. If it's not working, you have to change the treatment. Okay. So psoriasis, this is a common question that's asked. Curing psoriasis. This one is always you will say no. I just say it's like diabetes. So once you got it, it's for life. But when you're on treatment, it looks like you're in remission. That's the only way you can tell them. Food related is not food related, but if the patient is very obese, if they lose weight, it can definitely help. So generally, you can say you can follow, if they want to follow any diet, you can say Mediterranean diet. Okay, vaccine is no problem for psoriasis. Okay. Also, there's very high genetic preponderance. If both parents got psoriasis, 75% of the time the kid will have it. One parent is only 15%. So this is the form of psoriasis in children. So in children, they get this kind of psoriasis called guttate psoriasis. It can be self-limiting, but it can, like after a couple of years, the patient will get the plaque psoriasis. So depending on the genetics of the patient. Okay. That's all about psoriasis. Okay. Connective tissue. Connective tissue is usually I have to have some collaboration with the rheumatologist too. So it's not only me. So connective tissue disease, another name is collagen vascular disease. Okay. 75% of the time when the patient has SLE, they will have cutaneous features. Okay, and then the cutaneous features may be the first sign. They may not have the what do you call, cerebritis, the nephro problem, but they may have just the skin features first. So some of the risk factor is genetics, environment, the own immune response of the patient, and autoantibodies. So this is mala rash or the butterfly rash. And then you must see that this can be mistaken for facial eczema. You must see that it spares the nasolabial fold. because maybe you can remember that the sun really doesn't touch into this area. If you have eczema, everywhere will be involved. It won't spare the nasolabial fold. So if you have a patient with face eczema, and just pull see the skin inside the nasolabial fold. And then it will last for hours or days, okay? Similar to eczema, which actually lasts for days or weeks. Right, and then other forms, so this is not malar rash lah. So this is another form, which is the diffuse and papular erythema. So they have it on the fingers, on the upper body. This can be mistaken for a drug rash or a viral rash, viral exanthum. And the most severe form of acute cutaneous lupus, it looks like TEN, or toxic epidermal necrolysis. So then they start to lose the skin in the big sheets. So that one is a very severe form. Okay. So subacute cutaneous lupus. This is what I mentioned earlier also. So subacute cutaneous lupus, it is less commonly associated with SLE. Means just because the patient is diagnosed with subacute cutaneous lupus doesn't mean they will have SLE. So it's just a cutaneous lupus. And then it can be actually also drug-induced. So, but of course, when they have these features, you need to screen them whether they have systemic lupus or not lah. And the skin lesions last longer than a malar rash. It lasts longer and it actually can scar the patient a lot. And it's always in the sun-exposed area. So they present with this psoriasiform rash. And then it looks like circles and all that lah, with central clearing. And it leaves this pigmentation. So this pigmentation can be black or can be white. And then it leaves telangiectasia. Chronic lupus or DLE. So they present with like atrophic kind of scars, okay, and hyperpigmentation and hair loss. So it's commonly in patients who are darker. So Indians are very common to get DLE, okay, and what do you call? Of course, Asians in general is very common to get DLE, okay. And then commonly it's located on the scalp, the ears, the cheeks, nose, and lips. So they get these scaly plaques, okay, and scarring alopecia. So also it leaves a mark on the patient. Also, this one is just to remember again about the diagnosis of SLE. You have clinical criteria and immunological criteria. Generally, we will do all the immunological testing to make sure that it's not systemic. Okay, and then this skin biopsy. Skin biopsy, we will always send for 2 specimens. The purple one over here is histopathological examination, and the green one over here is called immunofluorescence. So when a pathologist sees this, they can diagnose it very easily from the biopsy. Okay. Yeah, because sometimes, as I told you, the blood test might be negative. Even ANA is usually positive. DS, DNA, and other things may be negative, but the skin biopsy indicative of cutaneous lupus. Okay. Okay, blisters. Okay, blisters can be seen in many conditions. So a common one to dermatology is actually pemphigus, which is autoimmune blisters. So it forms lesions inside the mouth and also on the skin. So it's very, very painful. And it is like non-stop. Once the blisters resolve, it starts back again. So it's very, very distressing. And there's a few subtypes of these pemphigus. So it can look differently. Okay, and this is more severe. Okay, so any age group, children rarely have it. So it's young adults to elderly. Okay, so they get this. So if now I'm talking about pemphigus vulgaris, later I'll show bullous pemphigoid. So don't mix these two terms up lah. Pemphigus vulgaris is PV, bullous pemphigoid is BP. Because the lesions look different. So the blisters in PV or pemphigus vulgaris is thin wall and flaccid. Means it's actually very lembek, the blister. If you press a bit the blister, it will pecah. So that's when it's called pemphigus vulgaris. Okay. And then usually it has clear fluid or like in this case, a bit of pus. And it can arise on the face, back, scalp, anywhere basically, and or the body fold areas. Okay. Diagnosis, very easy to diagnose. Clinically, also quite easy to diagnose, and also skin biopsy, which with immunofluorescence as well. Management, you have to stop the inflammation process. You have to give systemic steroids. They respond very well and very fast, but you can't give it long term, so you will switch to other non-steroidal agents such as azathioprine, mycophenolate mofetil, cyclophosphamide, and this biologic medicine called rituximab. Okay, this is BP, so bullous pemphigoid. You see the age also is different. The age is very elderly, so it's 80 years, 90 years old patients. So especially patients with neurological dementia, Parkinson, stroke, they will get this lesion. And it's not as painful as PV, okay? But it's super itchy. It's so itchy. And you can see the blisters are different. They are thick wall and they are super shiny. And they are not easily to break. Even you push them, press them a bit, it doesn't break. Okay, and the blisters may be like this, like yellowish in color, or it can have blood inside. The reason PV and BP is different is because the blister forms in a different, skin have many levels, so they forms in a different level of the skin. That's why the blisters looks different. Okay, so the blisters in bullous pemphigoid forms more deeper in the skin. So the blister is more thick. Okay. And this one is the immunofluorescence, also looks different. Even from the age group of the patient, you can tell which one it is. So the treatment is using very, very strong steroids topically if the patient has just a few lesions. If the patient has many lesions, you have to use systemic. Okay. And we also use doxycycline for this because of the anti-inflammatory component. And all the other steroid sparing medications like cyclophosphamide, azathioprine also can be used. But you must remember the patients with BP is very old, so you will use the more gentle medications for them. Okay. Another form of blisters is bullous impetigo, right? So just now I showed you impetigo like this. When it forms bullous like this, sometimes the doctors don't know what it is. So it is generally treated with topical and oral antibiotics. So usually I use, not Cloxa is the recommended one, of course, but usually we use cefuroxime or augmentin. Okay, and also some general advice: don't touch the areas, good hand hygiene, don't share towels and all that. Yeah.
Just not the antibiotic.
Pemphigoid. Anti.
It's not to cover and briefly for secondary, potential secondary.
Yeah, it's given long term actually.
Okay. So do we actually prescribe antibiotic as a preventive measure?
Yes, if you find there's any pus or it looks infected, you must prescribe.
Can primary care setting actually treat the pemphigoid, or we refer to dermatologist?
To diagnose, you would need to refer to dermatologist. Once the patient is like under control, because pemphigoid it will go into remission. So when the disease is very active, usually they are under dermatologist lah. Once the disease is become very quiet or just a few lesions, I think that one can be diagnosed and treated in GP.
And for this was skin biopsy, can it be done at the primary care level, or it can only
actually it can be done in primary care level. I rarely see any GP doing it. It's such a simple procedure. Yeah, we use a punch biopsy. It's like punching a paper like that. But the only difference is in some cases very easy lah, where you want to take the biopsy to get the answer. Because a lot of the times the pathologists are reading the slide, they really depend on what's our clinical diagnosis. From there, then they'll try to find it in the. So if your clinical diagnosis is not right, then they have trouble also. But definitely GPs can do. So easy. GPs actually do more serious suturing and all this. So this is nothing. Okay. In Australia and all this, the GPs do punch biopsy, is normal. Right. So bullous cellulitis, also the treatment is roughly the same as a non-bullous cellulitis, but it usually takes longer to resolve, and then most of the time needs IV. We cover with inside the guidelines or the antibiotic guidelines, they usually say cloxacillin, but in general practice we give augmentin, cephalosporin, rocephin, all this. Sometimes have to add clindamycin for the gram-negative. Okay. Yeah, linezolide and all this we will give if it's like MRSA lah. Okay, drug eruption. Okay, drug eruption it can look like anything, drug eruption. So it can look like measles, it can look like blisters, can look like bullous pemphigoid, it can look like anything. So how to say? And the reaction time also is different. Can be immediate, like you terus makan the ubat, within few minutes you get the reaction. Or it can be few days, can be weeks, even months. So when it's immediate, it's always like anaphylaxis or urticaria. So it's very rare for the patient like to have a drug allergy and then within 1 day develop Steven Johnson or something like that. It's impossible. Okay, within 1 day is usually urticaria or anaphylaxis. This delayed reaction, which is 6 hours to weeks, is the common one. So it's due to the IgG antibody immune complex and the cytotoxic T cells. Just not very clear. Okay. I'll go through a few kinds of the drug allergy lah. So when you want to find out which is the drug, you need to draw a timeline or a time frame. Like see what's the date that the rash started, and then you go backwards up to 2 weeks. What is the medication that was taken? Okay. And you may need to call other GPs to find out because they may have gone to a few GPs. So you have to see what is the most likely medication. So the most likely medication you will see most probably is an antibiotic, anti-epileptic, and the common one now is allopurinol. So allopurinol is some doctors, not GPs actually, some specialist doctors are giving allopurinol for just a high uric acid level without gout, without the symptom of gout. So, and then the patient gets the allergy lah. So that's quite dangerous. And then besides clinical diagnosis, blood tests, blood count with high eosinophils, deranged liver function, kidney function supports the diagnosis of drug allergy. This is a common one that you see, maculopapular eruption, MPE. So it looks like measles. So it's 1 to 2 weeks after taking the drug. And then it can still progress 1 week after you even stop the medication, it still progresses. This is the natural history. And then if you take the medication again, maybe wrongly take, the rash appears faster and faster. Okay, so usually it starts on the trunk and then spreads to the limbs. Okay, like example of chickenpox, it's always start on the head and then spreads downwards. So they have different way of spreading. And usually quite symmetrical. So both arms will be involved or legs will be involved. So Steven Johnson, a more serious form of drug allergy. Genetic component is very important for it. Certain people are just more prone to get it. So anticonvulsant, allopurinol is common cause. Bactrim is another common cause. Penicillins always. And also NSAIDs. NSAID is very common to cause Steven Johnson syndrome. So they form this ring-like structure, okay? They call it target lesion. So you have three rings, a red ring, then a pale ring, and then a center. So the center is usually dark. This picture is a Caucasian, so it looks white, and it usually has a blister. So this is called a target lesion or ring lesion. And then the mouth lah. So the mouth, the eyes, any mucosa can have erosion and ulcers. Okay. This is the most severe form of drug allergy, which is toxic epidermal necrolysis, and it is in a spectrum actually from Steven Johnson. So Steven Johnson, the skin area involvement is less than 10%. TEN is more than 30%. So in between 10 to 30%, you call it Steven Johnson TEN overlap. That means it's somewhere in between, but of course it can progress to just full-blown TEN. So it is what happened to the skin, it looks like it's burnt and then it starts to come out. You just have to touch the skin and then the skin can come out. Okay, and then mucosa is most of the time is involved. Okay, and then it has a not only morbidity, has mortality is also pretty high. But the treatment of this, actually there is no specific treatment to treat this TEN. So that's the sad thing lah. So basically supportive treatment, because the patient will have a lot of water loss. They can go into acute renal failure. The temperature will be haywire, be very high sometimes, hypothermic, because they cannot regulate the body temperature already. And then they cannot eat because the inside the mouth is all ulcers, so they be on tube feeding. And then the skin also, you cannot find a line most of the time. So it's very, very difficult to take care of these patients lah. So IV medications, usually we give hydrocortisone, immunoglobulins, IVIG, and then latest, lot of hospitals lah. A lot of data shows giving oral cyclosporin very early on in the disease helps to bring down the inflammation. And then usually these patients are in the hospital if they survive for like 1 month or so. Okay. Some miscellaneous. I think I have 3 miscellaneous things. So tinea capitis, just to mention, because this is very often misdiagnosed as a scalp abscess. So tinea capitis usually in kids who play with stray cats, okay? Or their own cat also can be actually. That goes outside, it can be. So it's a scalp ringworm. So it's caused by Macrosporum canis. So this blue picture here of with the scalp, it is under a Wood's lamp examination. When you look under the Wood's lamp examination, the lesion will look a bit greenish and will have fluorescence. So that's when you know that this is Microsporum canis. Okay. Other kinds of fungus won't cause this fluorescence. A few kinds only causes it. And as I say, it's always misdiagnosed as a abscess, and then the patient will undergo IND, which is unnecessary, will cause a scar on the scalp, and then the hair also won't grow nicely. Okay, the treatment in general is just to give oral antifungal, and the duration of oral antifungal is quite long. 4 to 6 weeks the patient needs to take it, and sometimes they need to be on additional antibiotics as well. So the oral antifungal that I use is okay. So oral antifungal that I use is griseofulvin or itraconazole, and then 4 to 6 weeks. All right, so urticaria. So urticaria is like these mosquito bite lesions, okay? Commonly called gegata lah in Malay. So they come and go very fast. They can be come and go within minutes, and then sometimes they stay up to a day, 24 hours. So acute urticaria is less than 6 weeks duration, and it is usually doesn't reoccur after that. Chronic urticaria is the one that will keep on reoccurring. It's more than 6 weeks. It goes like remission, active for life. Okay, and these patients with chronic urticaria sometimes can be difficult to treat. The antihistamines may not work for them. Okay, so now there are some new biologic medications that have been come out that targets the IgE itself. So they are on these medications for long term. So they are injectable medication. So angioedema is a form of urticaria actually, but it's involving the deeper tissues. So it is swelling and swelling, basically eyes, mouth, throat, and then can also cause difficulties in breathing. So the causes of urticaria angioedema can be food, can be drugs, can be infection, and then there's a form of hereditary angioedema as well. So this one will have family history. So the mainstay of the medication is antihistamines. These are the ones that we use. Usually Bilaxten, Telfast is the one that works well. And the dose is increased 4 times, meaning normally you give cetirizine 10 mg daily for whatever, flu or what. But in urticaria, we need to give 20 mg BD. So it's 4 times the normal dose. Then only it will work. Then usually the pharmacist will call you, are you sure you want to give this dose? Yes, because the indication is different. Same with loratadine, you give 20 mg BD, Telfast, Bilaxten, everything will be 2 tablets 2 times a day instead of the 1 tablet once a day. Right? And then the duration you need to continue on, I will say a minimum of 2 weeks. Tell them whether or not they have the rash, just take it for 2 weeks. And then I don't really like to give steroids for urticaria, because when you stop the steroid, the urticaria tends to come back with a vengeance. So usually I try to tell the patient, just take antihistamine. The first few days you have to tahan lah, the rash will still come. Okay, and then this omalizumab is the anti-IgE we use for very resistant cases. All right. So lip dermatitis, also common and difficult to treat, difficult to diagnose also.
We times
yeah.
2 weeks.
Mm.
So after that, do we taper down or
Yeah.
how do we taper?
You depending on the symptoms. If the symptoms is very, very well controlled in that 2 weeks, I will taper down to like half of it. So 1 tablet twice a day. Don't stop it immediately. So lip dermatitis, the reason that it's difficult to treat because it has many causes, multifactorial, because the lips touches so many things, and also the patient has a genetic predisposition. And some patients have atopic dermatitis that just present as a lips dermatitis. Okay, and then some behavior of the patient, like they like to lick the lips. Licking the lips also can cause a form of irritant contact dermatitis, right? And lipsticks, foods, especially foods with artificial coloring, and environmental factors like smoking or exposed to like other allergens, like what's that thing? Like braces, metals, a lot of elements for lip dermatitis. I find it quite difficult to treat. Okay, and then even toothpaste, some patients can have some allergy to toothpaste. Okay, so the treatment of this, I will say use no color lip balm, no fragrance lip balm, no lipsticks, and then try to prevent licking the lips too many times. And of course, I will give them some topical steroids. Yeah, I will give usually mometasone or Elomet. For daytime, for nighttime, I'll give them something else. I would give them non-steroidal. I'll give them maybe Elidel or Protopic. So the steroid is to be used short-term only, around 2 weeks. So 2 weeks we use the steroids. After that, tell the patient to continue with non-steroidal. I think this is the last miscellaneous one. So this one, or alopecia areata, whereby they have acute onset of hair loss in patches. So usually it's focal. Can have one or can have multiple. Sometimes it's scalp, sometimes it's eyebrow, sometimes it's beard. So for a man, you check those areas. Body hair is usually intact, right? And there is another form of alopecia areata, quite like this is everyone can diagnose that very easy. They have a diffuse form. So meaning like the patient looks like they're having male pattern hair loss suddenly. So that one, like from thick hair, suddenly they look like they have the male pattern hair loss of the front become thin. That is actually a diffuse form of alopecia areata. If you're not sure of the diagnosis, actually we do scalp biopsy. Because alopecia areata, the findings in the scalp biopsy is very characteristic. So easy to diagnose. If the poor patient is actually just having male pattern hair loss, so then you need to prepare the patient, tell them that these genetic factors, you can't do much, but you can slow down the progression only. Oh yeah, this is the last one. So nails, a common thing that you may see is the lines on the nails. So these lines, just to tell you, these lines are very, very common in Indians. So a lot of Indians have these lines on the skin. It's because of the pigmentation of our skin. So what we have is these longitudinal bands. Sometimes they may be as dark as this, sometimes it's brown in color. The reason that this is important is because the most common form of melanoma in Asian people is nail melanoma. So, and you see, we have quite bad luck. We get pigmentation on the nails and we get nail melanoma. So when the patient has some pigmentation on the nails, just take it seriously, just have a look properly. So because we don't get the melanoma that is like Caucasian, like from the moles, change of moles, that one is very uncommon in Asian. Asian is always the nails, fingernails or toenails, okay? And then, so the nails, you get something called Hutchinson sign, whereby the pigmentation actually goes out to the skin, So this is called Hutchinson sign. This is a sign of actually melanoma. Normally, it doesn't go out to the skin. Usually, we use a dermatoscope, like a magnifying thing, to see the colors, to make sure the colors are like lebih kurang the same, they are in straight lines and all that. If not sure, we actually biopsy this. We biopsy the nail bed. That means we remove the nail, then we biopsy the inside. Send that to the lab. If it's melanoma, then we have to actually stage the disease. Okay, yeah, that's all I think for my talk today. Any questions from here? From here, anyone?
One very common condition that we see, especially at the rural area, is cellulitis, all sorts of cellulitis. And I think one of the reasons being, and also in the plantation where we're dealing with the foreign workers.
Yes.
And it's left being untreated when they come to us. And by the time they come to us, they probably need an IV antibiotics, but they will refuse to be referred. And what do we do? How do we deal with this kind of situation?
Okay.
If we would give them, say, IM antibiotic, what would we recommend? And do you use combination therapy?
Yeah, this is a good idea. Actually, if they really refuse, IM is a good idea. IM rocephin would be great because it's just a daily dose, and I would add oral clindamycin. Because clindamycin, we also use IV clindamycin for the severe cellulitis. So an IM rocephin and oral clindamycin. And IM rocephin, I guess you won't continue for 14 days. You give for the initial part, and then later you change to augmentin or something like that. Yeah, say 300 mg BD. I will give if very bad, 14 days. And some patients I see antibiotics after 14 days, they still need antibiotics one. Then I change the antibiotic.
So we only use one at a time.
One at a time, yeah. And sometimes the very severe cellulitis, you check whether they need antifungal or not. You see they are in between their web space, look at their nails and their soles. It helps a lot if they even take antifungal plus antibiotic. It helps to improve the thing. So antifungal, you can use itraconazole, fluconazole, terbinafine, any of those. Is it from here? Yeah. Can methotrexate be prescribed by GP for patients? Of course can. I have some patient that is under GP on methotrexate. Just need to monitor them. Initially, when you start methotrexate, we will check the LFT and FBC after 2 weeks. Once the patient is more stable, at least every 3 months, you need to check the bloods. Okay. Yeah, it's no problem for a GP to prescribe methotrexate. How to differentiate bullous pemphigoid and bullous impetigo in primary care level. So remember, bullous pemphigoid happens in very old people, 80 years and above. Age group, bullous impetigo happens in younger age group, and impetigo usually in children. So that's how it easily diagnosed. And also bullous impetigo, the blister is very flaccid. That means it's very soft. So even you just scrape a bit, it come off. Bullous impetigo, it will stay there very firm. Okay, Raja asked which lesion, fresh, bullous, or dried one for punch biopsy? Okay, that's a good question. For bullous pemphigoid, we actually like to take the whole blister out. So you just choose the smallest one. Choose the smallest bulle, choose the smallest bulle, and then use the punch biopsy for that. So punch biopsy got different sizes lah. Start from 2, 3, 4, 5, 6. So 6 mm is the biggest one. You choose a blister that is roughly around 5 mm, then you punch the whole thing out. You get a very nice finding. If there's no small blisters, then you take a fresh blister, you punch the edge of it. Okay, so you must take two punch. One is for histopathological examination. One more is for immunofluorescent. So the histopathological, that is in formalin. The immunofluorescent is in normal saline. This is how you put it. What is the most suitable treatment for pregnant lady with steroid refractive SLE? This is difficult. I think this one, pregnant lady, we said they are definitely under rheumatologist and gynecologist. So this one I cannot comment because patients with SLE, we only deal with the cutaneous features. Sometimes they may have steroid refractory, means any steroid cream they use on them doesn't really work. So we give them the non-steroidal cream, like Protopic, like this, we give them. What's your opinion on chemical debridement for eScar if patient refuse escarotomy? Okay. So this one also, well, if patient refuse escarotomy, you can't do much. Chemical debridement, there's a lot of new products out in forms of dressing, gels that can cause chemical debridement. Of course, it's not as good as a surgical debridement. If you have no choice, you can use these new dressings like Aquacel AG. A lot of these hydrogels and all this can cause chemical debridement. Honey can also cause debridement. Yeah. Cannot hear. You give stat dose of steroid for urticaria only when it's very severe. Usually the stat dose already given by the ERMO lah. For me, I don't like to treat urticaria with steroid unless it's so severe. I already tried antihistamine for like 2 days and it's still very severe, 4 times dose of antihistamine, then only I will give steroid. So urticaria for pediatric group will be 4 times as well. Supposedly, yes, according to the guidelines, but in clinical practice, even I don't give that. Usually I give 2 times only the dose. And pediatric urticaria is very easily to resolve, so it doesn't need such a high level of medication. May I ask how's the tapering dose? Okay, so the tapering dose, when we start is 4 times. After 2 weeks, you assess the symptom and see if it's very well controlled, you can drop it to 2 times. That means cetirizine will be 10 mg BD only. Then you see back the patient either in 2 weeks time, then you can do cetirizine 1 tablet per day for a month and then you stop. So if you taper like that, then it's much safer for the patient. Am I right to say if the pigmentation of the nail does not exceed the eponychium, it's safe to say it's not a melanoma? That's true. But in early lesion, you actually have to look at the pigmentation to see the color is around the same color. So if it's brown, everything looks brown, and then it's in a straight line. So that is also indicates not a melanoma. So the pigmentation not exceeding the epinecium, it can be early melanoma also lah. So you need to use a dermatoscope to see the color. For nail melanonychia, are there any way we can treat? Oh, no. If the patient is concerned about the aesthetics, no. Because nail melanonychia, why you have it is actually because you have a nevus and mole under the nail that is producing this. Unless the patient, you remove the nevus under the nail, which will cause the nail to become damaged. It will never be smooth again. So the risk is, it will look uglier than the line itself. So you just leave it alone. How do you manage a child with very dry scalp with tinea capitis? Oh, yeah, okay, good question, Raja. So the patient has very dry scalp and also tinea capitis. Hopefully the tinea capitis is a correct diagnosis. That means you have sent the hair, culture it, the patient memang have contact with the stray cats, okay, then it's correct diagnosis. You give them oral antifungal. Topically, you don't need to give topical antifungal. Right? Topically, you can even apply, sometimes I put topical steroid there. Because to reduce the inflammation, to promote the hair growth, I will put topical steroid on the scalp, but eat oral antifungal. So, and then I will tell the patient to use olive oil and all this to moisten the scalp. Yeah, topical antifungals can actually cause the scalp to be more dry actually. So I don't do that. I think that's the last question, huh? Ariata.
How do you treat it? Does minoxidil actually help? And how long if it does, how long do you treat
it does help, but it's not the first line treatment lah, because it's autoimmune, right? So you need to give a steroid for that. You can start with topical steroid first, because some patients, they don't want injections straight away. So you start with topical steroid, you see them back in 2 weeks' time, you see if there's hair growth or not lah. If there's a really good hair growth, then no need to do anything. If the hair growth is super, super slow or no hair growth, then you give them intralesional steroid with triamcinolone, okay? So the percentage of triamcinolone, you have to dilute according, if you're using 40 mg, is different and 10 mg is different. So for scalp, I use around 10 mg per ml. So the 40 mg you divide into 4 with lignocaine. So, and then don't inject every week. I would say inject every 2 to 4 weeks. But you do know like alopecia areata is a self-limiting disease actually. Within 6 months, you don't do anything, also it grow back. But the patient is anxious, right? So you must make faster. Minoxidil I use for patient which is a bit more resistant. Like they have many patches of alopecia. So I give it like a second line. I inject the steroid also, then I ask them to use the minoxidil also. 2 things.
So for the oral steroid, topical steroid, what do you use?
I use mometasone and then even clodum, because clodum comes in a solution. Solution is easier for a scalp. Yeah, for beard and all this, usually topical or injection. I had one patient who lost the eyelashes. It's pediatric. Actually, I have 2 patients who lost the eyelashes. So eyelashes, what can you put? You can't put steroid. You cannot inject. Also have to use non-steroidal, Elidel and Protopic. It grew back. I think if I didn't do anything, also it grew back one. Discord.
So sometimes it's a bit weaky, so
Yeah.
sometimes you can misdiagnose.
Yeah.
So, usually the first time treatment
Moisturize first.
Moisturize. Then we start using
Steroid. Yeah. It's always, GP will always put antifungal on it. Oh, true, but it won't help at all. Yeah. You need to be a Foban cord, then it will help. If you're really scared of infection, give an oral antibiotic and a topical steroid. Yeah, I give Foban and it's become worse and worse. You need to suppress the inflammation. Mhm.
Or like another thing, for like normal eczema, right? Then of course you have to moisturize it. I mean, will like what's the difference between the normal moisturizer, the lotion, and also the one with ceramide? I mean, is it better? I mean, when do you recommend the one with ceramide?
Okay. For patients with eczema, because eczema patients have less ceramide. Generally, eczema patients would be better with ceramide. Patients with just dry skin, no need ceramide because price difference is there.
Yeah.
And also, if the patient have a lot of lucre, scratches, you cannot use ceramide. It's very per day. So you go with non-ceramide first. When they get better, then you can start to use ceramide to improve the barrier. And the brands that we use is like those, Ceradan is a common one with the ceramide. Can we prescribe Fusicort or fusidic acid for PITS patient on the facial eczema with excoriation? Fusidic acid, of course, can, because that one is just antibiotic. Fusicort, I would say can, not for long term, just for a short while. If you want to improve it very fast, you give Fusicort for like say less than a week, and then you change to something milder like Foban Hydro. Hydro then you can use for 2 weeks or a month. Okay, for alopecia universalis. Okay, universalis means, totalis means no hair on the body at all. So universalis means no scalp hair, no head hair. Oh, this one is who has been on intralesional steroid, oral pred, methotrexate, azathioprine, improve but come back once we stop. Immunotherapy, you can choose how long would you use it for. This immunotherapy actually works very well in children lah. In adults, it's not so good. I would say if the patient have recurrent alopecia universalis, you have to tell them actually that it might be not a good prognosis. So you can try these. You can try low level laser therapy, low level light laser therapy. Those like caps with that light. PRP, yeah. There's nowadays we are using PRP also for alopecia. But the most probably the better thing that you do is tell the patient the prognosis is not so good. You might have to get a week. Because sometimes you do anything also, the hair doesn't grow. And if the hair is going to fall, it's going to fall. You cannot stop it. So like I said, any topical for lips with pigmented cheilitis? Yes. So topical, I don't give lightening creams. I will give Protopic for that. So Protopic treats the inflammation. So if the pigmentation of the lips is due to inflammation, which is cheilitis, so it will help with to lighten the lips. Oh, this one I pun tak suka. If a patient says the eczema become better with lavender essential oil. Okay, generally we cannot use essential oil for eczema, but I also have patients who say that what I can say this is because the lavender is a fragrance. Fragrance allergy is not immediate. Fragrance allergy is delayed. You can tell them, yeah, now it's okay, your eczema is okay because the allergy didn't come in yet. In a couple of months or years, you might get it. Then you might not know what is the cause, and this could be the cause. Because study shows that you shouldn't use essential oils for eczema. Any kind, lavender, lemon, anything. Will ceramide work for people with just dry skin without eczema? Just dry skin without eczema or waste of money? I would say it's a waste of money if you just have dry skin. A normal moisturizer would do. Because the price difference is maybe double or triple. Okay. And also, dry skin, you need a lot of moisturizer anyway, so why would you want to use such an expensive one?
And
Elidel. Pimicrolins. There's only 2 that is available. So that one you can safely use for lips, for eyes. No, that's a good thing. There's no maximum duration.
but thin layer, I mean, I'm assuming it's safe to use on.
Yeah, thin layer, no need to be so thin. Just a layer. And then even if it goes inside the eyes a bit, it's okay because there's actually some eye ointments containing tacrolimus too, so it's actually safe for the eye. The thing about tacrolimus protopic is it causes burning sensation. And this is a common thing after, in the beginning, when they just studied for the first 7 days, they'll find that it's really burning. So you have to tell them that that is normal, that's how the medication is working. After 7 days, you won't feel it. When they go out in the sun, they will find it burning. I don't know if you've tried before protopic. So eyelid eczema, we use protopic, which is tacrolimus ointment. So tacrolimus ointment, you have 0.03%, which is less than 1 year old, we use that. And then after more than 1 year old, just use 0.1%. Okay, black box warning. Yes. So actually the black box warning is like to say wrong. It's been already proven that it was wrongly labeled for protopic. So black box warning was that in beginning, many years ago, when they just released this medication, they found that after several years, the patient using protopic, some of the kids got lymphoma or leukemia, some blood-related cancer. Then they put this label, black box warning label on protopic. But then many years have passed, and actually this black box warning has been taken off, so it was wrongly labeled. And it's actually very safe. If they're very scared or still very scared, then you give them Elidel instead of protopic, because the black box warning was for protopic only. All right. There's no question. I have to go. I got some patients.